If we can just prevent one or all three of these age-related diseases, we have done a most extraordinary mission for human health.
Dr. Eric Topol is a cardiologist, scientist, and best-selling author who helped pioneer digital medicine and the use of big data to personalize care.
I realized the audience was the public.
Yeah.
And it changed everything.
His book, Super Agers, explores how science and technology can help people stay exceptionally healthy and cognitively sharp into advanced age.
We're no longer in the era of, I don't want to know. We want to know because there are things we can do.
At the Scripps Translational Science Institute, he leads efforts to bring wearables, genomics, and AI into everyday medicine. He joins us to discuss how technology is reshaping patient care and what's on the horizon for data-driven health.
We have to get a grip on our immune system.
Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Well, Dr. Eric Topol, welcome to the Future of Medicine. Welcome to Stanford. Thank you for being here.
It's great to be with you, Dr. Ewan Ashley.
Well, it's a pleasure. We've known each other for a long time. I've been very inspired by you and your work, and I think your influence only becomes greater. You are known as maybe the futurist in medicine. Just a huge influence on the way so many of us think about the future of medicine, the future of healthcare. But I wanted to start not with the future, but with the past. And really your past, because one of the things we love to do on this forum is hear a little bit about how people got to where they are. You weren't always a world-renowned cardiologist with hundreds of thousands of followers and multiple best-selling books. Tell us about when medicine first became a thing for you. Did you always know you were going to be a doctor? Where did you grow up? Tell us a little bit about your background.
Well, thanks, Ewan, about the futurist. For me, I was in college at University of Virginia. I was working on a thesis on the future of gene therapy in man. This is 1975.
That's pretty early.
Published.
Yeah, gene therapy.
That's kind of the pattern with me. It always takes decades longer. So I usually get it right, but I'm off by 10 or 20, 30 years.
But everyone else is catching up. So
anyway, while I was doing this, I wanted to be a geneticist. And that was the major. And I wound up by trying to work part-time night shift in the hospital, UVA hospital.
Okay.
I got a job as a respiratory technician just by happenstance.
Yeah.
And I would change the equipment for ventilators in the ICU and on the wards. And it hit me that these people who I was working on their equipment, I thought they were going to die, and then days later they were going to be fine. I said, wow, this medicine thing looks pretty good.
It works.
So that influenced me to pursue it, and I had to then take some extra courses to go pre-med during the time at UVA.
But so this wasn't something as a kid growing up that you thought about medicine. You were headed towards genetics.
Yeah, I thought genetics was really the thing that interested me the most. It was in the early stages, of course. It was when the whole idea of recombinant technology was coming about, and it really allured me. But I really pivoted. I always maintained that genetics was fascinating. But I said, you know what? I got to be practical. Wouldn't it be great if I could be one of those doctors that help these people that are critically ill to get better? So it was a late move within the time when I was at UVA.
Yeah. And that took you to medical school then?
Yeah, so I applied to medical school. I wound up at University of Rochester in New York, and there I went through that program. I met my wife then, and I didn't know what I was going to be, but I wound up at UCSF for residency. I thought maybe I'd be a diabetologist or endocrinologist because my father had end-stage diabetes with all the complications. I thought about being a pediatrician. And then while I was at UCSF, I had this, for the person that was the biggest influence in my career, Kanu Chatterjee. And he, told me, he asked, what am I going to do in my life? I said, well, maybe this. Maybe you have to be a cardiologist.
That sounds like.
So that was. He made. I talked about it with my wife, and she said, he's right. You should do that. So that's how I wound up in this field.
Oh, pretty amazing. We've heard on this podcast other times so many stories of people being influenced. It seems, particularly in medicine, single individuals often change the course of people's lives. It sounds like that was the case.
He really did. I mean, as he did with so many others.
Yeah.
And I'm thankful to him because he recognized something that I wasn't even in touch with.
So where did that take you next?
Yeah, so after I did the residency, we wound up in Baltimore, Johns Hopkins, for fellowship.
Right.
And then basically I've had 3 jobs since fellowship.
Okay.
The first was 6 some years at University of Michigan, where I ran the cath lab. Then I went to be head of cardiology at Cleveland Clinic for 14 years, and now 19 years at Scripps Research. So the longest I've ever lived in one place in my life.
Has now been in San Diego. Yeah, of course I got first to know about you, and many others did, as really I think the world's most influential cardiologist from your position at the Cleveland Clinic. How do you think about that trajectory? Because you said spent more time in San Diego, but for a long time you were really very focused on cardiology. In the more recent past, it seems, especially with your recent work and the books you do and the content you provide is much broader. But for the longest time, it was really all about cardiology.
Yeah, I mean, it was cardiology, but even in the mid-90s while in Cleveland, we started back the first cardiovascular gene bank. So every person had a cardiac cath, we'd have a sample, as long as they gave consent, to put into a gene bank. So, I was kind of going back to some early roots.
Yeah, right.
But what happened was, this is one of these serendipitous experiences. I went to San Diego to start the first human genomics institute. There wasn't one,
I see,
even though there was a powerhouse of life science.
Yeah.
And within weeks of arrival, I went to this program that was organized by Qualcomm, and they had this guy stood up about that we're going to have a smartphone. This is 2007 in February.
Yeah.
We're going to have a smartphone that's connected to the internet, and it's going to have a camera.
Yeah.
And you can take pictures, and then you can send them to your friends. And these people stood up. I was kind of sleeping in the back. As people stood up and they said, "Wait a minute, we don't need a camera on the smartphone because we have these point and click really good cameras. What kind of camera is going to be on a phone?"
Kodak makes those.
Yeah.
We have all we need.
Yeah. And I'm thinking, whoa.
Yeah.
So all of a sudden, I got into this whole, I already had some ideas about digital medicine.
Yeah.
But that was the year in November that the iPhone was released.
Yeah.
So that was, timing was extraordinary because we were preparing a big NIH grant, and it was going to be just on genomics. And we then became the first applicant for genomics and digital.
Yeah.
And it wasn't just cardiology, it was across the board. So that was the transformational, just by happening to be at that one meeting.
That's
and
so
I
interesting.
almost slept for the thing. But the people that were raising a ruckus about why do we need, I said, what do you mean, why do we need it? Are you kidding? That's a sensor.
Yeah.
Do you get that? What else we could put connected to a smartphone?
Right. And Qualcomm, of all places, I mean, they're the ones who make those sensors, make the electronics that are inside.
Exactly. And I didn't even know when I went to San Diego how rich the wireless digital assets were in terms of the brain trust there.
Because the original reason that made the move was for a genomics
Exactly.
institute. I see. Yeah.
It was funny because I was interviewing here and at Scripps, and here they didn't want to put up the funds to do it.
I see.
I met with John Hennessy.
Yeah.
You know, he said, "Well, we got some other priorities."
I see.
And they really were eager to get it designated and to build it. But we basically changed the name quickly to translational because it was a broader thing.
Well, we think of you as a very close friend of Stanford anyway.
Yes.
I guess things might have been so different. But I think in some ways not so much. The world has moved in the direction it has, and I think from that perch, I think in San Diego, it's like a real hub of both genomics, digital, life sciences, biology, biotech. You've really been able to have a platform to really influence the world as it moves forward. Was that part of your plan? Because the idea of being an influencer, now they say all the kids want to be influencers when they grow up. I mean, you are an influencer. You were early. I remember one of the first times you visited Stanford after social media was a thing. You'd asked a bunch of the audience who was on Twitter at the time, and actually even at Stanford, only a minority of people put their hands up.
I remember that.
You do?
Oh yeah.
Yeah, but already you were creating a presence, and I think presenting information in a way, because I also think of you as like the ultimate kind of information gatherer and explainer. And I think that your Twitter feed alone is like a service to the world. But now you have these longer form ground truths and Substack that you have, where you explain science and medicine to a really large group of people. Was that something you were always headed towards, do you think? Or is that something you had to warm up to?
You know, that it's really interesting you bring it up. And again, you're being very kind. But my idea that our audience is the public and not our medical microcosm, it only hit me with the Vioxx debacle.
Right.
So this was back in 2004. Vioxx was withdrawn, and instead of letting it go, since we had written a paper in JAMA 3 years prior saying we got a real problem here, and only 3 years later they withdrew the drug, and the CEO of Merck claimed that that was the first time they had any signal, which was of course a lie. At any rate, I wrote my first op-ed, and so this is 2004, it's 21 years ago, and I realized that the public, the audience was the public, and it changed everything. And in fact, I always now encourage everybody to, not your audience isn't your peers, it's the much broader one, because your work, if it's going to be important, needs to include them and hopefully have a positive impact for everyone. So that was the beginning of the whole idea that writing, being on social media, that came up really beginning in 2009. But you know, building on that, and then you know, most recently I've really enjoyed this Substack Ground Truths, because it gives me a long form and a chance to interview people like you and people that are, I think, the most interesting, favorite people that are changing the future of health. So I try to get younger folks in my team and elsewhere to do this, but it's hard, because to write the first essay for the public or to speak like in the grand rounds, I would show those exact same slides if it was a lay audience. There's nothing I would show differently. I might be just a little more careful about abbreviations, but we shouldn't be using, you know, inside jargon. And we have to communicate the excitement of what we're doing and to the broad public. And I learned, I wish I knew this 30 years before I started doing it. But I think we're all learning that now.
I think it's such an important point. We try to train our residents and even grad students and others to understand that communicating science isn't just about, I mean, you have to learn to communicate to your peers, of course. That's an important part of publication. But the people who pay the taxes that fund our science, those are not them. I mean, that's just a small portion of them. The lay public are the ones who, first of all, will make a difference, but secondly, the ones actually paying for the science. And I think this move towards more open science and the idea of preprints as well, and their ability to make our science available quickly to everybody, but it also needs explainers, because not everyone has the ability to take something pretty complex and explain it in a simple and way. I
wish I could do even better. I mean, the only real criticism I've gotten from the Super Agers book, which has gotten a lot of non-science-based people to read it, is, well, why didn't you make it even easier to understand? I said, I tried, my editor tried, but you know, some of the things like the immune system and genome editing, these are tough areas to, you know, distill to completely common, understandable language. I wish I was even better at that. But I think that's the direction we all need to go. And when I am rehearsing with our residents and fellows about, we have these clinician scholars, we're going to rehearse the presentation. The one thing I do is, your slides are too, you know, inside baseball. You've got to make it so that anyone can understand these, and don't use your slides with all this stuff on it as a crutch. You should be able to communicate that with passion. And that, I think, is something that is perhaps one of the great things that it took me too long to learn about.
We should try to spread that word further around. I definitely want to get to your book, because I was really excited to read that. It's been very successful. But two things I wanted to clarify for our audience as well that they might not know or remember. I mean, you do talk about seeing patients, but you are an active cardiologist. You still see patients. Also, and this is to me the most remarkable thing actually, is you read all of those papers.
Yeah.
Not everybody realizes that. I think many assume that you have a team of 15 people who read it and put those tables together, but that's actually you.
The team is one.
Yeah.
That's me. People think that, and it's kind of crazy, but
Yeah.
I wouldn't want other people to, read or post for me. I'm trying to do it myself. And, I've always felt that way. Better off not to do it if you're not going to do it yourself.
Yeah. Which is great, and I mean today's Grand Rounds was a great example. I think 3 or 4 times you referred to work that came out in the last few days.
Right.
So this is obviously a daily ritual for you.
Yes.
Do you do it early in the morning or night?
I
or
do
what?
it early in the morning. I get up, 5:30 or so, and I'll spend a couple hours almost every day reading. I just like ingesting what is. And I love doing that. I've always been a voracious, Tyler Cowan calls it an infovore, and he's even much more of an infovore than I am. But that's, even when I'm on vacation and holidays, I'm still, reading. And that's how I learned. The difference is a lot of people read as much, they just don't share what they read.
Right.
And I think that's what, if we did more of that, we all would get smarter faster. So I think the main difference is it's not as much as the reading as the sharing.
Yeah, no, I think that makes sense. Well, and another way of sharing, and it's been maybe the longest form before new media was books, and you've written a number of best-selling books.
Every one of the books I wrote, I've been off by years. So Creative Destruction, I said we're going digital. The medicine world, we're still not quite there, but but that was like 15 years ago. And then when I said the patient will see you now, and it's all going to be democratized, we're not there.
Not there yet.
Then the deep medicine, we're going to be using AI. Well, we're starting, but I've tried to write books about where we're headed, thinking that it would not take as long, and I'm always wrong. I get the right idea with the wrong timeline.
I don't think you're always wrong. I think you're ahead, but I think in particular, think of this AI revolution that happened now. I mean, you were talking about the ways AI could impact care. Before it was probably GPT 1 to 2.
Well, at the time, I was 2017. I was pulling together, and I met with people like Fei-Fei Li here, Andrew Ng, and many others, leaders around, and they all thought that we would have something like a Chat GPT, but it wasn't really out there yet. It was germinating, and in fact, it really was with GPT-2, as you said. And this whole transformation architecture model. At any rate, it was widely anticipated that what happened at the end of November 22 was going to happen. It just when. That it could read and it could edit and it could write and then images and the works, right? So that helped me to kind of feel out what our deep AI world would be like, not knowing when it would hit. And then when it's hit, as you know, implementation is different than having the potential. And we're still early in trying to bring AI into medicine.
But obviously a huge focus for us here at Stanford, and I think because we have many of the architects of the revolution here. I know.
I look to Stanford as a leader in this space. I've been on Fei-Fei's AI board here, and so I see the talent pool is extraordinary.
It's amazing.
This, and particularly Kurt and the imaging, this is the leading imaging AI of anywhere in the country.
Yeah, it's been great. And I think sharing has been part of that, and obviously making sure that data is available to the world to compete and make the algorithms better. I think it's important also for us to be leaders in how we implement it in the world, and our digital scribe technology is going well. Like doctors really like that. Patients love it. Brings the doctor and patient closer together, and bringing the LMM into the patient's medical record. So not just a sort of secure version that we can use for the functionality, but rather an LMM that can read the patient's record, including not just at Stanford, but at the other centers where a patient has been through Care Everywhere, is pretty novel. Just a few months ago it was launched here, but there are already thousands of users, and it's very transformative when we've been used to that digital technology somewhat getting in the way of our patient interaction. We've got a generation of fellows and residents who are just really good at scrolling through screens to find the information we need, and now the technology, I think, can help maybe solve a problem that the technology kind of created.
Yes,
In
exactly.
the first place. So, but your most recent book, Super Agers, I mean, there's so much out there on aging, and so much. One of your first slides was about the supplement world. I think people really are desperate for and believe in that there must be some untapped, like, fountain of
Sure.
youth. But obviously, what is so great about your book is that it's grounded in evidence. It's grounded in also in our understanding over many decades of the diseases that are killing us. And I think that's what's refreshing compared to a lot of the content. But how did you decide to write a book on Super Agers? Maybe we'd love to hear the story of the patient that you mentioned and that you discussed.
Yeah, it's interesting. I've had a long interest when we did this Wellderly study.
Yeah.
It took 7 years. The idea, what is accounting? It's been a kind of a mystery. It's been in my mind.
Yeah.
And I thought we were going to nail it with the whole genome sequence.
Yeah, I did too. I remember
1,400
that
people.
study. Yeah, it seemed
And-
like it was a big enough study.
Yeah, and we saw basically nothing.
Yeah.
So we said, whoa, what is going on here? And the lack of the familial patterns of it, the age of health span and all that. So I saw the patient, Lee Russell, and here she was so intact. And I'm saying, I need to get back on this.
Yeah.
And at the same time, as seeing her, I had patients coming in my clinic.
Yeah.
And they said, I would give them some advice, and they'd say, well, that's not what Dr. Attia said.
Yeah. Right.
I said, oh, really? So I heard this a lot, like
Yeah.
I should eat 1 gram of protein per pound, and I should take rapamycin, I should get a total body MRI.
Right.
I said, what's going on
Yeah.
with this guy?
Yeah.
Now, I had met him. He used
Yeah.
to live in San Diego, and I read the book.
Mm-hmm.
And I said, wait a minute, this book, there's a lot of things wrong. There's some things good.
Yeah.
There's a lot of things wrong. And I said, we have some science here.
Yeah.
So, and I had been, because I'm a nut about organizing papers, I don't just read them, but I have everything filed.
Right.
I had it all ready to go in a way. Once
Yeah.
I decided I'm going to get into the whole health span, longevity space, somebody's got to do it.
Yeah.
And I pulled together, 1,800 different citations
Yeah.
and laid out the real evidence,
Right.
as well as a roadmap or where we can take that
Yeah.
with this prevention of disease thing.
So there's actually practical advice as well.
Yeah, so
Yeah.
basically, what do we know now?
Yeah.
What is the real deal on sleep and
Yeah.
protein and supplements and
Yeah.
you name it? And what are the breakthroughs that are occurring
Yeah.
left and right
Yeah.
that
Yeah.
maybe you don't know about, but they're worth building on
Yeah.
to prevent these age-related diseases?
Yeah.
Because if we can just prevent one or all 3 of these age-related diseases, we have done a just most extraordinary, bold mission for human health.
Yeah. Yeah.
So while I have been, even in San Diego, no less, up here in the Bay Area, there's all these huge investments in companies
Yeah.
to reverse aging and slow the aging process directly. And I wish them well.
Yeah.
And they have billions and billions of dollars and wonderful large
Yeah.
investors. But that will take a long time. It may not be safe.
Yeah.
A lot of these things, actually induce tumors and, have sequelae that are
Yeah.
not so light.
Yeah.
So I said, wait a minute, isn't there a safer strategy?
Right. Right.
And so that was the inspiration to go after this whole primary prevention of age-related disease. So while I was doing the research,
Yeah.
I didn't know where it was going to take me.
Yeah.
But then I started saying, wait a minute, we have these aging clocks work that was done here at Stanford.
Yeah.
We've got these incredible biomarkers, and we got all these other advances in omics and sensors and AI,
Yeah.
particularly multimodal AI. So it gave me a whole kind of perspective. How do we put that all together?
Yeah. Yeah, and I mean, I think that just this, it's become, I think, almost as common in the popular parlance now, as everybody has understood longevity and living for a long time, but they understand the idea of living well, living healthy. And I think putting that in this context of your individual patient was a really good way to kick off the evidence trail that was coming. Because I think at some level we're all very aware that there are people out there who are living very sharp mentally, physically with lots of connections to an older age, while there are others, and we see them, who are 40 or 50 years of chronological age, but might as well be 80 or 90
Exactly.
from an aging perspective.
Yeah, and the fact that we can anticipate these diseases 20 years in advance, and we can find out which organ is out of kilter for its pace of aging.
Yeah.
When Tony Wyss-Coray published that paper in 23, and I know Tony, but I didn't know that work was coming. I thought that was the most seminal paper I'd seen in years.
Yeah.
And I think it's going to have a huge impact on how we get ahead of people's age-related diseases.
Yeah, I was lucky enough to know that the first author in his lab and be part of his committee here. And so I had a chance to see that work as it evolved over the course of a few years. And I think you mentioned, of course, Steve Horvath's work in the early days, and the idea of starting to think about clocks. We've thought about, within cardiology, about heart age for a while, and trying to help people understand, you know, if they're younger than their age, their heart is younger than their chronological age or not. And so we've slowly but surely been putting a bit more detail on the idea of an aging clock. But I think he really put significant biological detail, single individual tissue detail onto that for the first time. But a lot of the questions then come, what part of it is about measuring it, and then some of it is about intervening.
Yes.
And so I wonder what are some of the things that maybe surprised you the most as you were doing this. I mean, you're this information sponge.
Yeah.
I mean, for me, I hadn't been following the p-tau 217 story, and I actually am a homozygote for APOE4.
Oh, wow.
And so you showed the slide of 1 in 4 people are heterozygotes, so have that increased risk. But I'm one of the 2 in the 100 that has a significantly increased risk, so I pay particular attention to this work. But as a biomarker, it really does seem
it's amazing
to be a significant.
And for me, as a carrier,
Yeah.
when I got it, and it was almost zero. It was very reassuring that I've got a good stretch where I don't need to worry.
Yeah.
I'll get it again in a number of years to see if there's any change. But you know, I think people who are at high risk, it's a good test. It's been around in the U.S. for over 2 years, and people don't know it.
No. Yeah.
That's what gets me, is all these things. A lot of them I had sprinkled through the book, of like the mammogram that tells you that you're high risk, even though it's normal, you're high risk in the next 3 to 5 years for breast cancer.
Yeah.
People should have that information, and we're no longer in the era of I don't want to know.
Yeah.
You know, the Cassandra effect.
Yeah.
We want to know because there are things we can do.
Right.
And plus, we're getting to know about accuracy and timing that would never have been thought was possible. People talk about weather forecasting at incredible accuracy that's coming because of the multimodal AI.
Yeah.
But this is something that is precious to have that type of arc for your health, for your life.
I love that you'd highlighted Morris Gerstung and Ewan Birney's work that was in Nature a few months ago, because I think everybody now has a sense of what a language model can do. It's predicting the next token, the next word. It can produce very human-like responses because of that. But that's also a time series of events. In that case, events are tokens, but if the tokens are not words, but rather health incidents, we should be able to bring this kind of technology to the fore to really help forecast for people.
Absolutely, and what's amazing about that is, this is from millions of people. We don't see those patterns. We don't have superhuman vision like AI does.
Yeah.
And so it picks it up. And what's also, fascinating about it is that was just with the electronic health records and some data on lifestyle. When they took polygenic risk score, it took you to a whole other level of accuracy. And that didn't include any biomarkers or organ clocks or, So to me, that was an ultimate validation that with all the things that are percolating right now, we're going to say, you are or not at high risk, and when, and here's how we're going to not let that happen.
Yeah, and I think you made this point exactly as well, and there's data to support this, but it's the granularity, I think, of that information.
Yeah.
People sort of understand risk generally, but then they respond with a general, like, well, maybe I should do a bit more of this, and the standard lifestyle things. But I think there is evidence to support when they have something very specific, like this is about you, and about your risk. It makes it much more real.
Well, see, this was the problem with polygenic risk scores, and still why they're not widely adopted. At the individual level, if you were at high risk, you don't know when.
Yeah.
So you could be when you're 90 or 95.
Yeah.
You don't know.
Yeah. Yeah.
This is different now. Now you have these different layers of data, and you have temporal timing specificity. So if you look at the large health model, you say you're going to have a heart attack in 7.9 years. Okay, that's a whole different look.
Yeah.
Now
yeah.
it may be off by
Yeah.
a plus or minus some months,
Yeah.
but this is a whole different way of prediction of high risk. That's not just specific about yes, no, but the timing is what takes it to a different level.
Yeah. You made this point as well that AI, of course, is here in the sense that the foundation models are built and available, and we're all in academic medical centers working with our own individual data and using the foundation models to see what we can do. And while inference is not completely free, individual inference is pretty cheap these days.
Yes.
And so one of our faculty and audience member made the point that if we add all of these things up and try to do it for every single member in society, that could be a lot of money. Well, first of all, people choose, if you add up the amount of money people spend on their haircuts over their lifetime, that's a lot of money. So
Right.
I think some of it is an individual responsibility element, and I think decisions might be different at a population level from a government perspective.
Yeah, I mean, I
than an
think the first thing, you don't do anything until you know someone's at high risk.
Yeah.
So the expense of these added layers of data, which don't include anything that's particularly expensive, we're talking mainly about omics or the AI's, algorithm.
Yeah.
But you don't even get to that unless you're, at a definite high risk.
Yeah.
So for the most of the population, plus you don't do everyone. You would start at age 40 to 50
Yeah.
to screen for high risk.
Yeah.
So not like the dumbed down approach we have for mass cancer screening,
Yeah.
where everyone, because they're age 40 or 50, gets this.
It drives me crazy.
And those are
Yeah.
expensive.
Yeah. Yeah.
Scans.
Yeah.
I mean, the questioner at Grand Rounds who doesn't realize how many billions of dollars we're wasting on mass screening.
Yeah.
Why don't we define these people's risk before we put them through screening, which has false positives, low yield, and and false negatives, of course, too. So I think that we can do much better than that. And the whole idea is, let's stop with this dumbed down age criteria.
Yeah, I think the idea that we define pre-probability as what age are you today, it just doesn't make any sense in a world where we have so much rich data to try and make an estimate. So, but I think it's always often with medicine, and I think you and I both spend a lot of time thinking about what would the future look like. I think in some ways, painting a picture of a great future is easier than deciding or not deciding, but rather than trying to plot the path from here to there.
Yes.
I think often about things in medicine, even like the blood pressure cuff. We measure blood pressure because that's a technology that was available a long time ago, but we still measure blood pressure, and then we do blood pressure trials, and so that's probably a marker for vascular health and a marker for a few other things that if we wouldn't invent it that way today. But how do we disrupt the past? Because you've also been a disruptor over your career in order to move us to that new world.
Yeah, I mean, I think there's some things that are so glaring important that we're not attending to. So we have to get a grip on our immune system.
Yeah.
It's fundamental.
Yeah.
And it's just unfathomable to me that, we're going to be 2026 and we have not a single way in the clinic to do that.
Right.
Right. I'm amazed.
Yes.
Our first crack will be the immune system pace of aging clock.
Yeah.
But we need more than that.
Yeah.
And so I'm hoping some really good work from here by Scott Boyd at Stanford and others they're going to help us get to a low-cost immunome that we'll get, as part of a yearly checkup.
Yeah.
We need that. The other thing is the images like the retina are so amazingly rich. And why aren't we using this?
Yeah.
We're leaving all this information on the table.
Yeah, it's literally a light into your blood vessels.
And
the only place you can see them.
I mean, you can tell about the heart, blood vessels, the kidney, the liver. I mean, risk of everything, and it's very inexpensive test to get. It should be part of our annual eye exam as we get older.
Right.
And not just that you get it, a picture, but that you get AI analytics.
Right.
So we'll get there eventually. But AI, a lot of patients today are taking their labs and they're putting it into ChatGPT or
all the time.
Gemini or whatever,
Yeah.
and it's telling them things that their doctor didn't tell them.
Yeah.
And explaining things.
Yeah.
And we're going to see a lot more of that. But I do think the U.S. is not well positioned for the large-scale preventive medicine campaign because of our malincentives. And it's much more likely because other countries are caring for patients at a true population level, not with insurance companies and all the ridiculous expense that we have here. And so they're going to invest, and they're going to take the AI and exploit it for prevention, because that small investment will pay huge dividends for reducing the burden of disease and the economic hit. Whereas here, I don't see yet the chance that we have.
We don't have that closed system where there's a real incentive to put the work in early to make the savings later.
So I do think we're going to see a lot more super agers outside the U.S. as a result of preventing these age-related diseases. And I'm obviously very disappointed about that, because we have that potential here, but it needs a lot of restructuring and making it conducive to caring for the American population.
Well, talking of other systems, I know you spent a little time in the UK looking at the National Health Service, and the Topol report has been, I think, pretty influential in their policy making over the course of the last few years. That's a very different system. That is a closed system. What were some of the real takeaways you had from that process, and then in your report for a system that really could achieve this holy grail if it wanted to?
I think the UK is likely to be the one to do this first. I was amazed at their aspiration to use AI, change the workforce, but use it to provide better care. And they, I got a chance, an incredible experience working with almost 50 people on a team to pull together. I didn't want it to be named after me, but they did that. They do this NHS review, and we came up with a lot of ideas, and I think they're on it now. They're obviously going through a lot of economic hardships for NHS that weren't all there when I was involved, but they're still committed, and they want to take this forward. That is, how do we prevent these just major age-related diseases now that we have the potential to do it? So the whole idea we have is do a randomized trial like we're going to do in Alzheimer's, starting in January, and then get to a point where we have interventions, call them preventions, and then export them to the UK to go grand scale. I think one of the big things about the metrics of aging that we have is that we can use those as surrogates that we're making a difference. You can't wait 15 years. Like the UK Biobank follow-up, 17 years. Well, we can't wait that long. If something really changes the trajectory of a major disease, we'll know it by these clocks and markers.
I wondered what, I was getting at this a little earlier with the question about what surprised you. I mean, you had these 1,800 papers as you pulled them together in the space. I think we are quite reasonably familiar with the disease-focused research, but you also dug into the aging as a biological phenomenon research, and I think you concluded that I think there's actually something there. It's just coming. It's maybe itself just coming of age, that kind of science. Whereas I think the public maybe think the other. They take the disease stuff for granted in a way, and believe that there's really a whole new science of aging. I think it's probably quite early, but just maybe account for us your take on that. Literature.
When the obesity story was cracked with the GLP-1 drugs, it kind of made me think, we've been working on that for decades, and most people were going to give up. And now here we have something, even though it looks like at the moment it's a forever drug, but it's huge impact. And of course the cost of these will just keep coming down and made into pills and on and on. So we have a precedent of something that is profoundly difficult. Now, aging is even more difficult than obesity, but with all the investments and some really good science, I changed my mind from it impossible to possible. And I think there's so many different shots on goal. The question is, if this is really expensive and it slows the aging by a year or two, it would be kind of like some of our cancer drugs today, where you pay hundreds of thousands of dollars and you get 3 more months of living. That's not going to be like what we're seeing in the world of obesity for intervention. So it has to be a really big impact, like a Benjamin Button thing. I don't know that we'll see that. Plus, I am worried about that when you start with stem cell factors or senolytics or these other strategies, this isn't kid stuff. So instead of just getting the markers, oh wow, the clocks have all gone reverse. That's great, but what about the downsides? So we can't just use the markers for these potent interventions to reverse aging. We have to get the long-term follow-up. Now, some people will jump the gun and say, if I can get 3 years younger across the board, my clocks and my body-wide aging, I want it. But you know what? They may be paying a price for that later.
And we have lots of people on rapamycin, on metformin, on all sorts of...
This is one of the other, this reason on the book is people can't, what dose of rapamycin should I take? I said, what? You know, this is what gets me is we have no way to measure the immune system. And these advocates like Attia and Brian Johnson and so many others, Huberman, telling people that they should take rapamycin, all of them at different doses, of course. And then now they're saying, don't take it because I get infections. You know, after years of telling them they should take it. And we have no way to check the immune system. So somebody could take a low dose, whatever that is, and their immune system could be shut down.
Suppressed,
and, you know, it'd be one thing if we could measure and titrate so that you don't disrupt an immune system's protection. But to play with that kind of
firepower.
Wow, I'm amazed at that, really.
So what is your, we just have a moment or two left, so what is your prescription then for all of us? If we want to be super agers, what are the things that we can and should do?
Well, the lifestyle factors, which are like 20 of them, they're fundamental, but we know we can't get everybody to do all this stuff.
And we're talking, it's diet, exercise, sleep.
And well, your area of expertise among many is exercise. That's why I did a podcast with you.
That was kind of you.
Because you are my go-to for that. And exercise is number one. And the biggest impact, not just aerobic, but also resistance and balance. And basically, I changed everything because of that. And the research is it's come along.
It's so compelling.
Wow. And sleep health, I changed. I didn't pay enough attention to that. I was a poor quality sleeper, no less quantity. Really got working on that. And of course, you know, having an anti-inflammatory, not pro-inflammatory diet, and being at the right weight and all that stuff. But then you've got social connections, you got purpose, you have being out in nature.
I love that. I read a whole book of that recently, and you talked about it a little in the book.
It's amazing.
The data also for being in nature is quite
It's amazing. It's amazing. And, you know, and we're lucky out in California. We have a better shot than people, you know, in the tundra zone, where I lived in Cleveland for many years. So, you know, I think, and there are many more factors beyond that. The point is, that is the easiest if everybody could do that. But in order to get people to be super agers, we have to even get beyond that. Because I know too many of my patients and friends that are very conscientious, but they get these bad diseases. So what can we do to prevent them? And that's where we need these immune system modulators. We need things that block inflammation in the brain and the body. That's where the GLP-1 drugs look very good.
They do look really good.
You know, and other things that are specific for the organ age-related disease at risk in that individual. So we're going to get there. I'm confident that. I am confident we will make a huge dent in age-related diseases going forward. And by the way, I think this is going to be the singular most important contribution of AI in medicine. Preventing diseases. People are talking about drug discovery. Drug discovery is going to be good to help prevent diseases, not to treat them, not just to treat, but help prevent. And all the other things that we're doing in AI in medicine for accuracy, for increasing humanistic interaction, they're great. But this one, I think, is going to be winding up years from now to be the biggest.
Well, apart from anything else, Eric, we're very happy that you're focused on super aging so we can have another 20 or 30 years of you leading us into the future.
I hope that comes about, but thank you. Really appreciate
Thanks for
that.
joining us here at Stanford.
No, I really,
so great to
that was
see
so
you.
much fun.
Yeah,
Thanks.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.